Hello and welcome, everyone. We are delighted to have you today for our webinar on Kaposi Sarcoma in people with HIV, new concepts in diagnosis and treatment. What you'll be seeing on your screen right now are a series of demographic questions for us to get a sense of who you are in the audience. So please go ahead and click through these questions, and it will basically ask you about who you are and a little bit about your background, just so we can get a sense of who's attending today. Great. I'm delighted to welcome you. My name is Dr. Esther Freeman, and I'm the Director of Global Health Dermatology at Massachusetts General Hospital at Harvard Medical School. And I'm so pleased today to be introducing Dr. Toby Maurer, who's a professor of clinical dermatology previously at UCSF in California and currently at Indiana University in Indianapolis. And relevant for this talk, Dr. Maurer is the lead dermatology in global health at AMPATH. AMPATH being the academic model for prevention of HIV and AIDS and treatment, sorry, mixed all those letters together, based in Eldoret, Kenya. And so she's going to be sharing a lot of personal experience working in sub-Saharan Africa over the last many years as an HIV dermatologist, and also some of the really cutting edge of where we are in Kaposi sarcoma diagnostics and treatment and care today. And we'll have some robust chance at the end for a Q&A. Next slide, please. So just to remind everyone of the conflicts of interest, these are relevant for the web board for IAS. Next slide. And also for our presenter, that Dr. Maurer reported no financial relationships with ineligible companies, and that I myself received some advisory fees on philanthropic programs for L'Oreal. Next slide, please. Great. And then today you do have continuing education credits. They are listed here. And this activity is designated for a maximum of 1.25 category credits. And please take a look at the IAS website for the instructions for claiming credits. And we thank very much our platinum supporters listed here today, including Gilead, Merck, and BIV Healthcare for their support of these webinar series. Great. You will see a separate window will show up with a poll question. You should have already seen some of those on demographics. And then in terms of submitting questions for the webinar for Dr. Maurer, we will be monitoring specifically the Q&A. So please do go ahead and put those in the Q&A rather than in the chat feature. And please include your full name and institution for the questions. The chat is really not meant for the Q&A. So please do submit that in the Q&A section. Thanks. So without further ado, so delighted to welcome my mentor and friend and close colleague, Dr. Toby Maurer, who is a dermatologist specializing in HIV, hailing originally from Canada, and has been working and living in the United States for a long time with a substantial body of work in sub-Saharan Africa, is really one of the leading specialists around the area of Kaposi sarcoma and HIV dermatology. And without further ado, I will pass it over to you, Toby.
Thank you so much. Really appreciate your kind words, Esther, and hope that this is all being seen.
And we are aware, just to let the group know, we are aware there's a little bit of an echo on Dr. Maurer's side. We did troubleshoot extensively going in, so just be a little tolerant. I think, Dr. Maurer, if you keep your head kind of right in the middle and the right in the center, the echo is minimized. So thank you, everyone. We are aware.
All right. Can you hear me okay? Okay, wonderful. There we go. All right, learning objectives. Summarize the latest information on KS, including epidemiology and diagnostic barriers. List the common treatment pitfalls in people with KS, and monitor patients with HIV for these potential complications, and describe how AI or artificial intelligence can be used in the diagnosis of KS. All right, Pat, we're going to ask a few poll questions here. What is your specialty, if you don't mind answering that? Oncology, derm, infectious disease, internal medicine, family medicine, or other? All right. And so what we're seeing here is mostly infectious diseases. Thank you. Good to know. Can we get to the next slide? All right. In which of the following patient populations, these are pre-test questions, is KS commonly seen in the modern era? A, Han Chinese people, B, newborn babies, C, patients with concomitant lichen planus, D, women who have never had sex with men. And next question, if we can get to that. Okay, before we do that, we'll see that C was the answer in the pre-test, and we'll go and review that at the end.
And just to clarify, Toby, I believe you mean that C was the answer most often selected, not necessarily the correct answer. Is that correct?
That's correct. Thanks. Trying to get to the next slide. Okay, we're a bit stuck here. Can we, there we go. Pre-test question 2. Which of the following is used for the diagnosis of early systemic KS? A, CT scan of the chest, B, PET scan of the abdomen, C, MRI of the brain, D, clinical history of signs and symptoms, and E, chest x-ray imaging of the lungs. And the most frequently answered question here is D, clinical history of signs and symptoms. Again, we'll review that at the end of the webinar. All right. There we go. All right. So here I'm showing you a bit of a historic viewpoint. Kaposi Sarcoma was named after Moritz Kaposi, who was a practicing dermatologist in Austria. A very powerful man, not the nicest of human beings, we understand. But he described what we know of as classical KS, which is really characterized in older, usually Mediterranean men. And this picture here of endemic KS, we see 2 elderly Greek men who represent brotherly love, i.e. not sexual intimacy, apparently. So we'll leave it at that. But these 2 gentlemen are the classic of classical KS. Fast forward to 1982, when I was in public health school, a gentleman from the CDC came in and mentioned that there were 13 gay men who presented with Kaposi sarcoma lesions. Well, of course, this was the beginning of the epidemic of KS. That is the AIDS epidemic. And as you all know, these are the types of patients that we saw during the era at the height of the AIDS epidemic. really ravaged by Kaposi sarcoma. As an intern in 1987, I was admitting just loads of these patients every single night who died within months of admission. Well, we then got antiretroviral therapy, and in 1996, in US and Western countries, we were thrilled because we saw that KS almost disappeared completely. But hold on. In 2007, we started to note a cluster of patients who had Kaposi sarcoma. They presented with what looks like this: small distal lesions, usually on the feet, not much to speak of. These patients, though, had high CD4 counts, low viral loads. In fact, they never had low CD4 counts. They weren't old, they weren't Mediterranean. What was possibly going on with this group? Who were they? Why were they presenting with Kaposi sarcoma? Turns out that these patients demonstrated what we call immunosenescence. And we reported this in the New England Journal, that there was a group of patients who had markers of immunosenescence who were presenting with well-controlled HIV. So let's go forward and look at what the incidence of KS is now, 12 years beyond that, and now even beyond the 12 years. I want to present to you a patient who really comes in with a couple of little lesions, 62-year-old heterosexual Korean female living in SF. She's got 3 lesions on the bilateral feet. A biopsy was done in Korea and did in fact show Kaposi sarcoma. When she got here, she was rebiopsied again, HIV tested twice. In fact, her husband was even HIV tested. She was pan-CT scanned, no evidence of visceral involvement, and was started on a topical medication called alitretinoin, for which she paid $8,000 out of pocket. This was not working, so she was referred to oncology to start chemotherapy. But she was sent to me for another opinion. Well, here's what's going on. Human herpes virus 8 is a ubiquitous virus, and it is the virus that causes Kaposi sarcoma. It is seen in 5 to 10% of the population. 50% of the population in sub-Saharan Africa have evidence of HHV8 in the serum. We've known for decades now that in San Francisco, in men who have sex with men, at least 25 to 37% of men who have sex with men harbor this virus. The global incidence of HHV8 is about 33%, and we see this all over the world. In fact, 50% of HHV8 is seen in the Han population of China. So what turns on HHV8 to make it a KS lesion, either cutaneous or systemic? And the bottom line is, we really don't know. There are some theories. Steroid use, for example, growth hormone, ACE inhibitors, perhaps, maybe even concomitant viruses, CMV and HHV8, EBV and HHV8, that might turn on HHV8 to become a cutaneous or systemic KS lesion. And I love this article called Double Trouble When Herpes Viruses Join Hands. So there is some evidence about that. And what about relative immunosuppression? Well, I want to bring to your attention a fifth type of Kaposi sarcoma in men who have sex with men who are HIV negative. The average age of this group is about 63. So again, not your elderly Mediterranean patient. There was some evidence that in this group, topical steroids were used more frequently, usually for psoriasis. No immunosuppressive drugs were seen in this population. And those who had the most severe KS had abnormal CD4, CD8 ratios, indicating that there may be some relative immunosuppression, turning that HHV8 virus into Kaposi sarcoma. So going back to our Chinese Korean patient, this patient, whose last name, by the way, was Han, did harbor the HHV8 virus. She did have KS. She was HIV negative. And this is all to say that if you see such a patient and you test them once for HIV, you don't have to keep monitoring them. We know that KS appears in HIV negative patients as well. Does this patient need chemotherapy? Remember, she was referred to oncology to start chemo for 3 very localized small lesions. I would argue no. And in fact, even in HIV-infected patients who present with localized cutaneous lesions, our first line of therapy is antiretroviral therapy. We wait about 9 to 18 months for resolution. And if those lesions are not resolving at that point, we would consider chemotherapy. In the HIV negative population, we do not start antiretrovirals because they're not HIV infected. We do nothing. And we monitor for visceral involvement or lymphedema. And I'll talk a little bit about what questions we ask for monitoring. If patients are very distressed by these lesions, we introduce intralesional vincristine, which we inject right into the lesions. We have also done some work injecting intralesional PD-1 inhibitors, nivolumab in particular. I'll talk a little bit about Maurer, and pomalidomide is a drug now that is being promoted for use in HIV negative KS patients. Let me talk a little bit about the nivolumab trial, which we just published a few days back. In this group, we enrolled both HIV-infected patients and HIV non-infected patients who had Kaposi sarcoma. We injected nivolumab into their lesions. 3 had complete resolution. 9 had reduction in their lesions. All had reduction in HHV8 positive cells within their lesions. And unfortunately, PD-1 and PD-L1 did not change in their skin biopsies, but circulating CD4 and CD8 cells decreased significantly, indicating that there was probably some systemic absorption of nivolumab, but without the usual side effects of IV infused nivolumab. So this was very well tolerated and safe. Maurer is a drug that we have used in HIV-infected patients with limited lesions. We found that in our KS patients, there was increased CCR5. Maurer is a drug that blocks CCR5. 15 patients were entered into this clinical trial. 2 withdrew because they had very advanced KS. But of those patients who were in the trial, 11 of 13 had reduction in the size of their lesions, 2 had progression. Of the 7 patients who had edema, 5 of them had reduction of edema. So currently in the HIV-infected population with limited lesions, we're adding this drug to the patient's regimen. We have not used this drug in HIV-negative patients. But I did mention pomalidomide or Pomalyst. This is an oral medication, cousin of thalidomide. The dose is 5 milligrams daily, and we use it for 21 out of 28 days. We add aspirin because there's some evidence of thrombosis on this drug. Really, there have been some small studies, but with some good response rate. In the HIV positive patients, we've seen a 67% response rate. However, in the HIV negative patients, the response rate really went up to about 80%, suggesting that this might be a very good drug for persons who are HIV negative with Kaposi sarcoma. I want to move on to our African patients because while things were looking good in the United States and Western countries, Jeff Martin, with whom Esther and I work, pointed out that there was a huge prevalence of Kaposi sarcoma in Africa, involving women. As you can see, here's a patient with extensive vulvovaginal lesions. I saw her. She died within about 4 months after seeing her, leaving 4 children behind. 12-year-old girl in the center here. Just to let you know that children also get Kaposi sarcoma in sub-Saharan Africa, usually presenting with extensive leg edema and not so many cutaneous lesions. And then this 30-year-old man, this is the classic of what we see in sub-Saharan Africa. Huge edema, huge lesions that coalesce, the typical situation. In sub-Saharan Africa, the incidence rate for Kaposi sarcoma is 334 per 100,000 person years. The mortality rate is up to 40% 2 years after diagnosis. As stated, it affects men, women, and children. Average age, 30 to 34 years of age. So we're really taking out a young generation of patients. And interestingly, 82% of KS cases that present to us in sub-Saharan Africa present in late stage, where it is usually too late to do anything, even chemotherapy. I'll talk a little bit more about that. Just want to go back to mention to all of you that Pat Moore and his wife, Dr. Chang, were the ones who really discovered that HHV8 is the cause of Kaposi sarcoma. And it is the same virus, regardless of the morphology of KS, and regardless of the type of KS. How's the sound here? Can I just...
It just got a little bit worse, Toby, but I think as much as you're able to keep your head still, it seems to be better.
Okay. we'll be in a stage position here. I also want to bring up this woman, Ethel Cesarman, who worked with Dr. Moore and Dr. Chang in their lab. And she is well known for what we call the latency-associated nucleic antigen, or the LANA stain. This is an immunohistochemical stain that binds to the virus, and we see it binding to KS cells that express latent antigen. This is a finicky stain that is very operator dependent. You're looking for this little spickling of pigmentation within the cells. It is, in fact, another piece of information. If you are biopsying a patient that might be suggestive of having KS, and then a LANA stain is done looking for this particular stippling. The reasoning, though, is if a patient has active KS lesions, should they not have higher levels of HHV8 in the blood? We certainly see HHV8 through the LANA stain on their KS cells. What happens in the peripheral blood? Well, unfortunately, there's no correlation to higher HHV8 levels in the blood, whether there are cutaneous or visceral lesions. So the bottom line there is we cannot measure HHV8 in the blood to give us a diagnosis of KS. However, quantitative PCR shows us that each tumor contains at least one copy of HHV8 in the KS lesion. The gold standard still, though, for diagnosing KS is histopathology. And we know this from the wonderful work done by two UCSF dermatopathologists, Phil LeBois and Tim McCalmont. However, we did look at amplified PCR in KS, and we did see that you could, in fact, amplify for PCR by using PCR and really see what the qualitative look of KS was. So we developed what we call this little field PCR instrument called Tiny, where we put tissue into these little areas here, and we do PCR on the tissue itself. And what we saw was very similar to doing that within the lab. We did see that the sensitivity and specificity was very similar to the sensitivity and specificity that we saw quantitatively in the lab, but this time using this instrument, Tiny, in the field. We also were developing a threshold over which we are looking at HHV8 viral loads. In other words, over a certain threshold, we know that you've got Kaposi sarcoma if the viral load within the tissue is over a certain threshold. Below that threshold, you do not have Kaposi sarcoma. So this is very good in differentiating the mimickers of Kaposi sarcoma, let's say like lichen planus, which presents as a purple lesion on the skin, not unlike Kaposi sarcoma. If you take that tissue, put it into this tiny instrument and amplify through PCR, we look at the viral load of HHV8. If it's above a certain threshold, the patient is said to have KS. Lichen planus would be below that threshold and therefore not KS. So we're using this, or hope to use this, where there are few or untrained pathologists, particularly in African countries where we have a real dearth of dermatologists, dermatopathologists, I should say. We want to also use this where there's a need for rapid diagnosis at the point of care, and also where there is a need for PCR confirmation if pathologists are unable to diagnose KS on past specimens. We have reproduced these results on about 550 samples from Uganda, and now we're working on 1,500 samples from around sub-Saharan Africa. I want to show you this picture, which I found in the archives. The guy here is a young picture of Paul Volberding, so important in our work at IAS. And he is joined by Marcus Conant, one of our leading dermatologists in HIV and KS. The two of them joined together, and you can see here their look on their face, trying to figure out in the mid-'80s what therapy they should use for Kaposi sarcoma, particularly in HIV-infected patients. And we have not gone too far. Again, as mentioned, first-line therapy in patients with HIV is antiretrovirals. We wait for 9 to 18 months to see if the lesions have resolved. If there are visceral lesions, we might add chemotherapy, and that first-line chemo is liposomal doxorubicin. So the big question is, how do you know if the patient has visceral lesions? Well, will an X-ray be helpful? Not at all. By the time you see X-ray changes on a chest X-ray, a patient with KS is very late stage and probably near death. What about bronchoscopy and colonoscopy? You can most certainly see lesions. Again, in sub-Saharan Africa, access to bronchoscopy and colonoscopy is not that accessible. So what we do is we ask about symptoms. Basically, is there evidence of hemoptysis? Is there shortness of breath that does not resolve with 4-drug TB treatment or antibacterials? Is there abdominal pain that is unexplained? Is there melanoma? Oh. And is there sustained lymphedema? And we're looking for sustained edema in the lower legs. If the answer to those questions is yes, that is a time that you are thinking of adding chemotherapy. Now, I'm going to also discuss a few predictors of survival. And one of the things that I had mentioned is that many patients who are on ART do present with KS in sub-Saharan Africa. In fact, a recent study has shown that 65% of patients with ART, or 65% of patients with KS are on ART successfully when they present. What other markers are there that predict survival in KS? Well, a recent study has shown that there's decreased survival in persons who have more than 11 sites of involvement cutaneously. Oral KS is a predictor of survival. Low CD4 count and low hemoglobin, also indicators of decreased survival. And how does chemotherapy itself change survival in late-stage KS in sub-Saharan Africa? Well, stay tuned. That's part 2 of 3 of the same study that we are currently involved with. What about chemo? We know that in the United States, chemotherapy changes the death rate from about 40% to 25%. For liposomal doxorubicin, you require 6 cycles at least with about $15,000 per infusion. You can imagine that this cost is prohibitive in sub-Saharan Africa. Fast forward to a wonderful study done by Esther Freeman, our moderator, who really tried to evaluate various chemotherapeutic regimens for advanced AIDS in Kenya, doing a cost-effective analysis. One of the drugs they looked at, or one of the regimens they looked at, is bleomycin vincristine, which we use in sub-Saharan Africa, I have to say, with not much efficacy, usually doing more harm than good. When comparing paclitaxel, a drug that we also use, we saw that paclitaxel really would have eventuated in saving 6,400 life years of patients. Liposomal doxorubicin probably would have improved survival even more, but it was shown that there needed to be a reduction in the price by 44% for that drug to be cost effective. I want to also point out persistent lymphedema. Even when we get rid of KS with whatever therapies are there, we see that KS infiltrates the lymph system. Patients have so much edema in their lower legs that they can't walk. It's painful. Their quality of life is greatly decreased, and they become fibrotic. Their skin becomes fibrotic. Well, we have to pay tribute to the Una boot, which is a type of compression bandage that was first described by Dr. Una. I like to talk about Dr. Una and Dr. Kaposi together because both of these gentlemen were classmates in Austria. So I feel like we're bringing them together again, resurrecting them together. We discovered that the Una boot was wonderful for compression. It needs to be changed weekly, but that it really did eventuate in decreased edema for our KS patients. And here is what we're looking at. You can see this patient with profound edema using these Una boots with decreased edema over time. So we are using this both in the United States and in sub-Saharan Africa. We have also added pomalidomide to those patients based on a study that showed that pomalidomide decreases edema in and of itself. And in addition, we usually keep patients on long-term liposomal doxorubicin that also seems to decrease the edema without terrible side effects. And here's why we want to reduce the edema. There are long-term sequelae in patients who have lymphedema, and that's mostly squamous cell carcinoma. I'm showing you two patients who had KS that were completely resolved. The KS was resolved through chemotherapy, but because of their lymphedema and skin breakdown, they developed squamous cell carcinoma, which metastasized and killed both of them. But it takes more than just having biopsy or diagnostic equipment and treatment. As was said earlier, 82% of KS patients present in late stage with a 40% mortality rate. There have been various campaigns, radio campaigns, posters, free biopsy services in an effort to get patients biopsied and seen at their earliest stages of KS. We've set up teledermatology such that patients who present with skin lesions can be photographed at their earliest stages. We've set up all kinds of navigation strategies, of which, again, Esther has been absolutely part of this whole effort to really get patients to where they need to be for early diagnosis and then linkage to care. And we're trying to understand the stigma behind KS, HIV, and cancer in sub-Saharan Africa that really present the barriers to both early diagnosis and linkage to care. Again, I just want to bring your attention to some of the outstanding work done by Esther and her team on stigma, some of the very focused qualitative work and mixed methods work that is done to really get at what we can do to erase stigma and improve early diagnosis. And again, some of those techniques that we're using are physical navigation, videos, providing travel stipends for transportation, enrolling patients right into their health insurance plans, giving stipends, and of course, peer mentorship. Again, wonderful work done by Sigrid and Collier and Esther Freeman. What about artificial intelligence? The dream, of course, is that someday a patient could even take an image of their own lesion. It could be fed through a computer-trained program, and a diagnosis could be made. We have analyzed and are in the midst of analyzing KS images, about 6,000 of them, putting them through machine learning to see, in fact, if we can use artificial intelligence for KS diagnoses. And I will say that a wonderful study that was done by Sarah Coates and company really did take a look at whether or not we could use artificial intelligence. The bottom line is that it's not yet sufficient for clinical use. We don't see the sensitivity and specificity that we should be seeing. We continue to crunch those pictures and a bigger sample size, and it is hopeful, but not yet there. And even with dermatopathology and those Lana stains, we're seeing if artificial intelligence can in fact help us with those finicky stains that we talked about. Nice work done by our group, Iftak Hussein and company, using novel techniques looking at artificial intelligence. Here we saw that the sensitivity and specificity were quite high using artificial intelligence in looking at these Lana stains. So I leave you with this notion that artificial intelligence used on images and used in pathology really have hopes in the future of making rapid diagnoses and hopefully earlier diagnoses. I leave you with these takeaway points. KS is still very prevalent throughout the world. There's a high mortality rate, especially in sub-Saharan Africa. Can we detect KS at its earliest stages? A lot of work being done to do that. Chemotherapy is definitely a treatment option, but it has to become more affordable. Stigma has to be addressed. Linkage to biopsies and care continue to be addressed. And of course, there's room for new treatment for both localized and systemic KS lesions. Going to end there, but go back to our pre-test questions and talk about what the right answers might be. You'll remember that the most frequently answered question on this one was C, patients with concomitant lichen planus. And the question again, in which of the following patient populations in KS is KS most commonly seen in the modern era? The right answer is A, Han Chinese. And let's see if we can go to the answer. But here we know that KS is not perinatally transmitted. The whole idea behind lichen planus, thank you. Han, you got it. The Han Chinese people, that's right. Patients with concomitant lichen planus, that is on the differential diagnosis of KS. And though we do see KS in women, we do not see KS in women who have not had sex with bisexual men. So we just don't see KS in women who have had sex with women only or without ever having sex with bisexual men. Next question. Let's see if we can get there. Not sure we can get there. Let's see. There we go. Question 2. Again, which of the following is used for the diagnosis of early systemic KS? Give you a chance to vote on that. Okay. And you got this originally correct as well as now, which is clinical history of signs and symptoms. That's the correct answer. And again, CT scan, PET scans, MRIs really do not show you KS. And chest x-ray also does not show you early KS. By the time you see KS changes on an x-ray, the patient is quite sick. So in fact, what we do use is clinical history of signs and symptoms as we reviewed. So you got that correct. All right. That's all I've got, Esther.
Great. Thank you so much, Toby. And we have a wonderful set of questions to share with you. Perfect. So, organizers, if you guys are just willing to take down those slides so we can kind of see Toby a little bit better. I wanted to start with some of the questions that were submitted ahead of the conference, and then we also have a number of great live questions as well. And I think we'll start with kind of a clinical question because I think one of the challenges with this is that it's such a practical approach when you have a patient in front of you, and sometimes it can be tricky a little bit how to handle some of these patients. And so one of our colleagues submitted a great question saying that they have a patient with long-term viral suppression and CD4 counts averaging around 400. He's been diagnosed with Kaposi sarcoma. Dermatologic lesions are slowly spreading and increasing, but oncology hasn't started any treatments at this time. How common is KS after long-term viral suppression, and are there any interventions that I should be pursuing at this time?
So this is a type of patient that we see not infrequently, who has done quite well from the HIV point of view. And so I would make sure that their HIV treatment is maximized, first of all. And then would really look at the localized features. So this patient sounds like they have KS, but are getting more lesions. This is a type of patient that you might want to do a course of liposomal doxorubicin on because they continue to get more lesions. And so this would really clear the slate. This is a patient in whom I would probably give the 6 cycles of liposomal doxorubicin. You would also not be wrong to start pomalidomide and see how that patient does. We should see a reduction in lesions on pomalidomide within 4 to 6 weeks of starting it. And of course, pomalidomide is an oral medication, easier to take. Neutropenia is a side effect, so you have to monitor for that. And of course, add aspirin to prevent thrombolytic events. But other than that, it's worth a try, and then perhaps move right on to liposomal doxorubicin.
And out of curiosity, because you mentioned several new treatments, you mentioned intralesional nivolumab, and I'm sorry,
Nivolumab.
thank you, nivolumab. I wanted to add an extra syllable in there. Intralesional nivolumab, and you also mentioned the Maurer data. So I'm curious, you didn't mention either of those just now. Tell us a little bit about your thought process of how you're thinking through what you would choose.
So for nivolumab, we injected it intralesionally. It is not yet approved, although we're hoping with this recent publication, there will be more thought about approving the drug. So that's kind of out. IV nivolumab, of course, is being used. Studies have been limited in our HIV population with KS. The first few patients who were treated with PD-1 inhibitors had some bad side effects to the PD-1 inhibitors. So they had a lot of thyroiditis, gastrointestinal problems that we see in patients with IV nivolumab. So I probably would not go to that. Now, Maraviroc, you could certainly add, and that would not be a bad way to go. But again, we had success with very limited KS. So in a patient who seems to be having flourishing KS, I would probably not go there as a first line drug. And I think that that's what we really have is Maraviroc and nivolumab. And again, nivolumab not yet licensed for intralesional use.
Okay, so that's why you were saying you would kind of start with the pimalidomide if you didn't jump directly to the liposomal doxorubicin. Okay, I think that also instance, Shannon Friery wrote a question in the chat, which I think was very similar, which is, are you adding Maraviroc at standard dose for positive patients, and how long do you continue it? So it sounds like that's not your standard of care that you would necessarily jump to right now, or it is.
Well, again, here's how I would use Maraviroc. If I had a patient who had limited KS, and I wanted to keep it at bay. Okay, so not for someone who has progressive KS, but really someone who has some lesions on their feet. They don't want it to progress. That's when I would add Maraviroc. And how long do I keep them on Maraviroc? Forever. Maraviroc is a pretty simple drug to take, very few side effects. And if it's keeping patients at bay, I'm pretty happy with that.
Okay, I think that's very helpful as we think about kind of choosing among these different therapies. So we also had some questions about, there seems to be a little confusion in the chat around who seroconverts to HHV8, saying maybe people get KS without seroconverting to HHV8. So I'm hoping you could just clarify for the audience a little bit about how potentially HHV8 precedes KS and why that's part of the process.
So all patients with KS have HHV8. That's just the way it is. And some patients we know, as I was saying, HHV8 is very commonly seen in the population, particularly in men who have sex with men, in other sectors as well, as I pointed out, even in the Han Chinese, throughout the world. It is a ubiquitous virus, and it just usually sits there, doesn't do much. And in some people, it turns on to become KS. And again, we're not entirely sure why that happens. Some thoughts are that patients have been on steroids, both topical, sometimes ingested steroids, even injected steroids into joints. That seems to, in some people, convert HHV8, quiet HHV8 virus into KS lesions. We know that growth hormone has also been implicated. And there was this question about ACE inhibitors. I don't have a lot of confidence in that so many of our patients in the world are on ACE inhibitors. And we know that HHV8 is not becoming KS in 33% of the world. So no.
So in short, just to kind of clarify the question, I think in the chat, it's just that there is a little bit of a misconception, I think, in some of the questions in the chat that maybe some people are getting KS without HHV8. So we say HHV8 is necessary but not sufficient, which means that everybody who gets KS has HHV8, but not everybody who has HHV8 goes on to develop KS. And that what Toby's talking about here is some of the triggers that might cause people to go from having HHV8 to actually then developing KS. Great. So I think there's another interesting series of questions in the chat. And just to let everyone know, we're going to be ending at 1/4 past the hour. I'm just going to know some people were thinking you were ending at the top of the hour, ending 1/4 past the hour. So we still have 10 minutes time for questions. So I think there was a great question coming from Christian Nicolas Roman Ortiz saying, how does HIV viral load and immunosuppression influence the emergence, progression, and treatment response of KS in infected patients? And are there particularly any HIV therapeutic strategies that we can use for management of the neoplasm in context of HIV? So basically, how does your HIV viral load and immunosuppression influence what you're seeing in terms of KS?
So we generally think that you've got to maximize your immune system. We definitely know that persons who have low CD4 counts, high viral loads, those are patients who get KS. So maximizing your HIV treatment is the number one thing that you can do to treat KS. However, as we reported back in 2008, there were patients who had always had viral suppression, maximized therapy, low CD4 counts, and they presented with KS. And it turns out, again, that those are patients who probably had evidence of immunosenescence. Where do we see immunosenescence? We see it in the age group between 50 and 60 in well-controlled HIV-infected patients. What can we do for immunosenescence? Not much that I know of, unfortunately. Whether this is actually a result of our HIV drugs, immunosenescence that is, or if it's just the natural aging process in persons who are HIV infected, we still don't know. But what to do about it? Nothing. So we watch and basically we maximize, make sure our HIV treatments are maximized. And of course, we have so many new treatments. So we watch that and we treat the KS as we need to.
And then Maria Gaba has a question about Tiny. And just to remind the audience, Tiny is the miniature travel-sized kind of portable PCR that we use for potentially diagnosing KS in the field. And she says she recently worked in a hospital in the Nuba Mountains of Sudan where there are patients with endemic KS. Is Tiny commercially available or available to be purchased by field hospitals like this one?
Thanks for asking. The answer is not yet. The prototypes for Tiny are currently being manufactured. And again, we are absolutely checking out the data over and over again. The people with whom Esther and I work will never release Tiny unless we have absolute truth to know that we can really use this with high sensitivity and specificity to really almost match completely what we see in histopathology. So unfortunately, we're a couple of years away, but
Watch
please
this
know
space.
that we do have, it's coming on down the pipeline, we hope, and with continued research funding through the NCI and NIH, as we hope that continues as well.
Yes, and as a follow-up question, and we see we have Dr. Geraldina Dominguez from the NCI actually joining us today, and she asks specifically if you would recommend radiation for limited KS.
Thank you, Geraldina. Glad you're on. And we certainly do use XRT radiotherapy for Kaposi sarcoma. It does work well. There is only a limited amount of radiotherapy that you can use before the skin breaks down. So we do use it. It's used to be first line before we had other treatments, which we now do have. So we really reserve that for patients who have not responded to these alternative treatments that I mentioned. It's really now a last resort rather than the first line for limited KS.
Great, thank you, Toby. And I'm just looking at some other questions here. I did type a response for Carmen Webster had a question about, are there any tools that we've developed around navigators that are used for screening HIV patients? And Carmen, please feel free to reach out to both Toby and myself, and we can chat a little bit more about some of the tools we have. Most of the navigation programs that we run have been once patients are diagnosed with KS, and our navigation program is about linking them into care and keeping them in care. But we certainly do so have some tools as a team that are around screening, so slightly different questions. So I'd say please feel free to reach out to Toby and myself after the webinar. We can chat with you in a little bit more detail about that. And let me just pull up a couple more questions here, Toby. So someone asks, do ganciclovir and valganciclovir have any effect on HHV8? And what about newer therapies like letermovir and mirabegir, if those have any utility, which I think kind of gets to this question of what do we do about HHV8? So,
Yeah. Well, we're always looking for the solution, so to speak, for HHV8 itself. And there was some early evidence using ganciclovir in CMV for CMV retinitis. The early paper in which they were using ganciclovir for CMV retinitis showed that those patients who were on ganciclovir, there were fewer KS cases in those patients compared to the group that was not on ganciclovir. So that started a lot of interest in whether or not ganciclovir could be used as a direct agent on KS. There was some evidence in the test tube that there were reductions of various HHV8 markers, but then studies that have been done in human beings have not shown that ganciclovir is helpful to get rid of KS. There has been a paper or two that has shown that it reduces the progression of KS. But again, no hard, solid evidence. We do not use ganciclovir for the treatment of KS in the US, in most Western countries, and we don't use it in sub-Saharan Africa, based on some of these previous studies that have really not shown benefit. And again, to that same question, are there specific agents that target HHV8? No, not yet.
thanks, Toby. So I think we're going to wrap up. This is going to be our very last question. And this comes from Claudia Pilati at Sinai Health. And she says, in patients with HIV who are already on antiretroviral therapy that present with KS, would you still wait and monitor for 9 to 19 months before potentially thinking about starting chemo? Or is this only applicable for your patients who have not yet started on ARTs?
So again, let me just get clarification on that question. This is a patient, Esther, who
patients with, so I think the question was, because I think you had mentioned at some point that there's a period of watchful waiting that you do.
Yeah.
I think the question was, in which patient group is that appropriate? And in which patient group would you come on right away and say, we need to do ART plus chemo?
So based on recent evidence that if your patient has more than 11 sites of involvement, of cutaneous involvement, I might be more likely to start chemo right off the bat. But if they had limited lesions and fewer than 11 sites, I would say, okay, we can do the watchful waiting and see what happens with the ART for 9 to 18 months. Of course, you would also want to make sure that they don't develop or don't have systemic signs and symptoms of which we spoke of. Again, that also includes sustained lymphedema. So if there's cutaneous lesions, less than 11 sites, without edema, I think you're safe to wait 9 to 18 months and monitor. Make sure that those patients aren't progressing rapidly and needing chemotherapy for perhaps visceral symptoms that they might be developing.
Thank you so much. And I'm sure all of you will join me in thanking Dr. Maurer very much for joining us today and giving us the cutting edge and also the practical approach, which is so needed for our patients that are often quite challenging cases when we have patients who are already on antiretroviral therapy and we're trying to understand when to start chemo, what to additionally start. So I found that to be extremely helpful. Just as a reminder that this is the presentation slides and on-demand recording will be available within 24 hours after the live broadcast, and also evaluation information on how to claim CME will be emailed by 5 o'clock today. And if you aren't receiving the emails, please go to the IAS-USA website. Next slide. And also a reminder for Going Antiviral, the IAS podcast hosted by Dr. Michael Sag on the measles outbreak and the role of anti-science is going to be coming up. And next one, to remind everyone that July 24th, there is an upcoming webinar on the true meaning of palliative care, maximizing functioning in the setting of disability. So for after the webinar, we will activate a link to evaluation form in your IAS-USA account under My Activities, and it will also be sent to you via email by 5 p.m. Pacific time in the next business day after the webinar. An additional upcoming event is July 31st. There's the complicated issues in the management of PrEP that is also coming up. And also on August 6th, the 2025 update on routine and special immunizations for people with HIV. And a reminder for the conference on bacteriophages in Washington, D.C. coming up in October. And with that, I will say a huge thank you on behalf of both myself and Dr. Maurer for joining us today as we talked about Kaposi sarcoma. Thank you so much, and we'll see you next time.
Thank you.